Good afternoon, everyone. I think we'll get started. Welcome to the fourth seminar of the Fall WRTC seminar series. My name is Kimberly Hill, and I'm a member of the WRTC as an MPP student here at the University of Regina. The WRTC is a unique program that brings together students, academics, decision makers to study issues related to health services research. The subject of today's seminar has been a growing issue for governments, administrators, providers, and the general public. According to a paper put out by the Canadian Health Services Research Foundation earlier this year, healthcare spending in Canada is rising faster than the economy is growing. The increasing costs have led to speculation around the sustainability of Canada's healthcare system. As a result, a need for understanding what drives these costs has come to the forefront for researchers and decision makers. Cost drivers are factors that cause an increase in spending in a particular activity. And today's seminar, Cost Drivers in Healthcare, What's Really Going On, will look to identify healthcare cost drivers, evaluate their impact, and discuss the implications for future health policy. It is my pleasure to introduce my professor and thesis advisor, Dr. Greg Marchildon. Dr. Marchildon holds a Canada Research Chair in Public Policy and Economic History and is the site director at the University of Regina for the WRTC. In 2001, he was asked to serve as executive director of the Commission on the Future of Healthcare in Canada that was chaired by the Honourable Roy Romanow. Dr. Marchildon is an expert in the area of health services research with a focus on health systems in Canada and other industrial nations, most recently completing a project in conjunction with the Canadian Institute for Health Research on Canada healthcare cost drivers, which will be released next week. Please help me welcome Dr. Greg Marchildon.
Well, thank you very much for the introduction. I know it's always a very difficult thing to stand in front of a whole group of people to do this sort of thing. And you're probably wondering about the timing because the release of the report by the Canadian Institute for Health Information is actually next week. This was set months ago, and the thought was that the report would be released actually just before the seminar, and you would have been sent a copy of the report. I apologize for that. Now, this report is a CIHI report. I am the principal author, but ultimately it's a CIHI report. And I have worked very closely with CIHI to figure out exactly what I can do today in terms of what is in effect an advance release of this report. And I want to thank them for being so generous in terms of allowing me to do this today and to allow this information to be provided to you. Some of the information and some of the data in particular are not going to be updated right up to 2011 because that will come out in the report. The second thing I want to emphasize is that my opinions concerning the policy implications and some of the dimensions of this are my own opinions. They are not the opinions of CIHI. And I want to separate myself. CIHI does not engage in what they call policy analysis. That's my job, and I do that as much as I like, and nobody can say anything about it because I'm a free person. But CIHI is not in that position. As you know, CIHI is really an instrument of the federal, provincial, and territorial governments, the governments that fund it, and the governments that, in fact, govern it. So it's subject to certain rules and constraints. Second of all, it's mainly a data collection and analysis organization. It is not engaged in the business of policy analysis. It does not have a mandate in that area. So this is going to be a seminar that largely focuses on the cost picture, the data, what the data tells us now after this year-long study by CIHI. And I again want to emphasize my role in this, which was to basically examine the technical reports. They were very detailed technical reports in every sector and try to bring it all together, as well as provide sort of an analysis of what it means in terms of the international picture. So there's a fair amount of work done by dozens and dozens of people that lie behind this. The other one thing I wanted to mention is that even though you won't get the report until the release on November the 3rd, which is Thursday, I believe everyone that's signed up will get a copy of the report. So we'll make sure that you get the full copy as soon as possible. Okay. This is what I propose to do, and it's really motivated by the conventional wisdom in the country, which is that an aging population and the cost of technology are basically threatening the sustainability of healthcare. And that is the conventional wisdom. You hear it over and over. And this cost driver's work really attempts to try and examine it and look at what the data over the past decade really tell us about what is going on. So it's a detailed look at these underlying cost drivers. Now, the other part of that is that it has to be subdivided into categories when you're doing this. So basically, when you're looking at underlying cost drivers, you're not so much looking at the sectors in healthcare that are growing most rapidly and the reasons why. You're trying to get at the underlying factors from inflation, both general inflation as well as health-specific inflation. And by that I mean inflation that's above the rate of general inflation. You're trying to understand the impact of aging, of course, and population growth. And then you're trying to understand other factors that have proven to be much more difficult to get at. And you'll often see them classified as this other residual category, but they include things like utilization and probably the most important, which is technology. And we actually know very little about those categories. And one of the readings that was sent in advance to the people that are a regular part of this seminar involves the contribution of technology in a particular area. And that's an example of the work that we do throughout the world on this, but it's, in a sense, sector by sector. It doesn't deal with healthcare as a whole, and we have very little idea of the impact of technology on healthcare as a whole. On the question of fiscal sustainability, I'm going to today put aside the question of the sustainability of private healthcare. That's another issue. And instead I'm going to focus like a laser beam on the public or the governmental side of healthcare. So you're not going to see much reference, if any, to total healthcare expenditures. We're going to focus really on public sector healthcare expenditures. And there's some things that you're going to see from this analysis that are going to be quite obvious, that, of course, healthcare expenditures have been trending upwards, and that's whether you measure it as a proportion of gross domestic product, whether you measure it in terms of real health expenditures per capita, both in absolute terms and the growth, and in terms of provincial and territorial health spending relative to revenue growth, which is where our decision makers are at, and that's what they're thinking about all of the time, and that's what preoccupies them. Now, I'll tell you right off the bat that there's a similar trend in all OECD countries, and we're going to see a couple of graphical representations of that. And that might lead you to the conclusion that there is not a problem, particularly when you look at Canada relative to other OECD countries. We look not too bad off, but there is still a problem. And the problem is that the last 10 years, and I'm going to use a strange measure of the last 10 years, from about 1998 to 2008, partly because of data, and partly because 2008 represents a pretty momentous shift in terms of the economy. It's a major downward shift. And so we can treat that sort of notional decade of 98 to 2008 as a period of growth and prosperity, where everything was going pretty well. Well, we're not in that period of growth anymore. You wouldn't know it perhaps in Saskatchewan or in Alberta, but in fact, we are in a period of great economic turmoil, and governments are seeing their fiscal dividends disappear. And even in prosperous places like this, there is not going to be the fiscal dividend that there was 10 years ago. So we may be entering another period of cost containment. You already see it in some other jurisdictions in this country where you see healthcare costs being cut in terms of cuts by ministries of health to regional health authorities, or at least controls on the rate of growth in the costs, and a number of changes. And I just read an article about New Brunswick in which the government said on the one hand that it would be actually cutting expenditures to the two regional health authorities, but at the same time it was still committed to primary health care, despite the fact that the regional health authorities then turned around and basically cut the hours of operation of the primary health clinics in their region from 24 hours a day to 12 hours a day. So that's the kind of situation that you get into, the kind of dilemmas and conundrums that you face when you're in an environment of cost containment. And we don't have to think very far back to remember what it was like in the early and mid-1990s here. So this is what public sector health expenditures to GDP look like as a ratio over time. And the trend line is the red line, and it shows it trending up from about 6% or a little less than 6% in the 1970s to just over 8% in 2010. Now the figure you always hear about is the 10% figure. And that's because they're talking about total health expenditure. I'm only focused here on public sector health expenditures. Now, looking at this, and as a policymaker would look at it, you'd see three distinct periods. The first period is the period from about 1975 to the early 1990s, and you can see the trend line there quite clearly. And then the early to mid-1990s, there was actual disinvestment in healthcare. This is all provincial governments and territorial governments aggregated. But you can see the result there. And then there was reinvestment by about 1996 on. And again, you can see the trend line. The one piece of good news is that in the last couple of years, at least in terms of that forecast that CIHI has provided, there may be a little dip, and it may be going down a bit, maybe to the level that it was in the 1980s. But if anyone remembers the concerns about expenditures in the 1980s, that may not still be a great story. Now this shows provincial and territorial government health expenditures as a proportion of total program spending. Now we're bringing it down to the decision maker within individual provinces and the kind of factors that cabinets face. You can see how it climbed pretty continually from 1998 to about 2004. And you can see that since 2004, it's leveled off. So we're not seeing this sort of inexorable arithmetic. It has leveled off. The question is whether it will continue to level off or even go down. But when you look in individual health sectors, hospitals, other institutions like long-term care, physicians, and drugs, you see something peculiar. You see that it's actually that the annual average growth rate has actually declined in every sector except for one. And that's in physicians, where it has grown quite dramatically. And that is comparing sort of the first part of that decade, 94 to 2004, slightly just a one-year difference in the reference period, and then from 2004 to 2009. Those are the light shaded bars. And you can see that physician expenditures, the average annual growth jumped up to 8.1% in the last 5 years. Now that's not inflation adjusted, but it's a very substantial hike. The other surprise here is drugs. You can see that drugs has fallen to about half of what it was, and I'll talk about that in a second. Now, let's look at Canada relative to OECD countries. The question here is, are we devoting too much of our economy to public health care? And what this tells you is, well, at least we are not doing so relative to OECD countries. Canada is well down in the list. The countries that are included here are countries that devote a minimum of $2,000 a year per capita to public sector health expenditures. So it basically eliminates all of the countries that have either invested less because they're poorer countries or they have predominantly private systems. But even the United States is captured on this list. And when you look at the United States, you can see that it devotes more of its economy to public sector health expenditures than Canada. And you can see that Canada is basically at the level or slightly below the Nordic countries. So really the situation here is not as dire as some would make it out to be at all. And in fact, we're in a pretty good position when you look at this kind of a ranking system. Some countries that are near the top, like France, have a reputation of extremely good healthcare systems, but they have a growth in costs and a level of expenditure that is probably getting into an area that you would determine as unsustainable if you were a government decision maker. But there's no question. They spend a lot of money and they have a very good system. And on many rankings, France comes out above Canada in terms of the quality of its healthcare system. Now, this is a little bit more complicated diagram, but this is plotting economic growth against health expenditure growth. And again, there are two things here. Number one, there's hardly a country that is below that 45-degree line. That 45-degree line, if you're right on it, means you're spending exactly the rate of economic growth. Basically, for every additional dollar worth of growth, you're spending a proportionate amount on healthcare. No more, no less. But you can see that that's not the case for most countries. Most countries are well above that line. They have been since the 1950s. And the reason for that is quite simple. Healthcare has been growing faster than the rate of economic growth everywhere for some time. It's a leading sector of the economy. There's a great deal of new science and technology that's wrapped up in it. And one American economist who did a major study for the National Bureau of Economic Research said that healthcare was the leading sector industry in the United States since the Second World War. Not the automobile sector, not any other sector, but actually healthcare in terms of delivering the most value added to the economy. So when you look at it not as a cost, but as a sector of the economy, which is both an investment and a cost, you think about it a little differently. But just in terms of what this diagram tells you, it tells you that we're basically all in the same world where we're dealing with a sector in which costs are going faster than both economic growth and obviously revenue growth in terms of governments. And Canada, and you can see the little red circle, I hope, on Canada in that diagram, Canada is doing reasonably well relative to those other countries. Again, a fairly positive story. These slides, I'm afraid they can't be posted right away, but they'll be posted on next Thursday, and you can have a good look at this diagram. And I hope it will be in the report. It was in the last draft I saw as well. So now, let's look at what's going on in terms of provincial and territorial governments and the federal government overall. This is an aggregate amount looking at basically what they spend and what they don't spend on. And what you can see is revenue growth is 1.4%. That's the black square, the far left. And then you see growth of average annual growth of 3.4% in healthcare from 1998 to 2008. That's relative to 2% for transportation and communications, that whole public sector. That's mainly a federal area, but there are provincial expenditures in that area too. Relative to 1.5% in education, relative to 0.6% in social services, which has seen a dramatic drop over the last 10 to 15 years. Now, the one I haven't talked about are the debt charges, and that's a negative 5.6. You might say, well, how can it be negative? It's negative because most governments over that period were running surpluses. And instead of adding to their debt, they were adding to the surplus. And that meant, in fact, that they had a fiscal dividend. And it gave them all kinds of room. And that room went into extra expenditures, and a lot of that was focused in healthcare. So that's basically the fiscal picture for the country from 1998 to 2008. So now let's talk about the underlying cost drivers. In this, we want to get a deep understanding of what's going on beneath the surface. It's not enough to know the overall growth rate or to even know, how fast physician expenditures are growing relative to hospital expenditures, relative to pharmaceuticals. We need to have an understanding of what is going on beneath that that's driving health expenditures in general and by sector. And that's why this cost driver project was launched about a year and a half ago at the Canadian Institute for Health Information. Basically to provide decision makers with much higher quality data and information so that they could begin to make decisions for the next 10 years. Now, there's going to be a policy response to the situation. And the question is by whom? The first focus is on provincial and territorial health ministers and their governments, in particular their finance ministries, but really it's about cabinet making the decision collectively. The second is the federal government, and the federal government's involved in a very major way through transfers. About 20% of provincial and territorial expenditures are really from the federal government indirectly. They flow into the general revenue funds of the provincial and territorial governments through the Canada Health Transfer. They can be theoretically reallocated anywhere. There's no strict obligation. There's an expectation they'll be put into healthcare. And certainly, you could argue that they certainly have been put in healthcare over the last 10 years. The linkage here is that it's not always easy to see how this works in terms of you have your provincial cabinets. They receive a transfer from the federal government. They raise their own revenues. There is then an allocation to the health ministry. Then there is yet another allocation to the regional health authorities. That's the bulk of the health budget. And then the regional health authorities in turn go through an allocation and decision process. And many of the actors involved in this process are not direct government employees. It's a highly decentralized decision-making system. And you need to understand that because it's not a command and control system like it is in other areas. It's virtually command and control when it comes to social services. Government decides what the welfare rate is, it decides the conditions of the benefits, it decides whether there are going to be other programs, but basically the provincial cabinet has complete control. When it comes to healthcare, that's not true. And I've drawn up this organization chart just to describe in some way that decision-making system, including all of the intergovernmental bodies that are involved. Yes, they're answerable to federal, provincial, and territorial governments ultimately, but they also have a degree of autonomy. And these, particularly those bottom organizations at the very bottom of the diagram, they do various specialized tasks on behalf of all governments in Canada, including providing advice like the Health Council of Canada, including CIHI itself, which provides data. It collects up the data, but then it provides it back in a digestible form to all governments and to the general public. So, the Canada Health Transfer. In 2014, that transfer, the conditions of that transfer basically end. There's going to be a negotiation long before 2014 rolls around. A number of statements have been made. I think it's still an open question about what happens. There is a built-in escalator currently of 6%. That will continue until 2014, according to the Prime Minister. But nobody knows where it's going, and there's a lot of discussion in the country about what this means. But remember, 80% of the money for provincial and territorial health is raised through own source revenues. It does not come through the health transfer. So, how important are aging and technology compared to the other cost drivers? We'll go through these categories: general inflation, population growth, aging, and then we'll look at that black box of other, what the economists often refer to as the residual. And that's where we're going to see health sector price inflation above the regular rate of inflation, where we're going to see whether there is increased utilization, I'll call it volume, and whether technology is having a major impact in the area. We're not going to be able to see very much when it comes to those other categories. There's some data and some databases that allow us to look at particular sectors and get a slightly better look at it, but it's still largely shrouded in mystery. And there's a lot of speculation about what's driving the other. And you can see this is graphically represented here. The other constitutes 2.8%, which is a fair amount of that total of 7.4% of average annual growth from 1998 to 2008. Aging, big surprise for some, I suppose. It only constitutes 0.8%. Population growth, 1%. And population growth is sort of often has a very beneficial effect, because population growth can often mean that you have a younger demographic. It generally means that. It means that they're probably utilizing the health system much less. It also means that you have more working age people contributing to revenues. So I think of aging and population growth as sort of the bad cholesterol and the good cholesterol. And you could look at it that way as we go through this. 2.8% is general inflation. We can dismiss that. We can discount for it. We can just say, well, you know, that's the whole economy's been subject to that kind of inflation per year. Let's discount it. So let's focus on population growth, aging, and other, particularly technology and volume increases. And that's what I'm going to do here. First, let's start with the issue of aging. This shows you the change from 1998 to 2008 in terms of provincial and territorial health spending. And you can see that it's highest for seniors, people between 70 and 79 and 80 and 89. But you can also see a little flip in the sense that it decreases from 1998 to 2008 in that 70 to 79 category. It increases slightly from 80 to 89. What does this mean? It means we're living longer. And so the curve is shifting, it's just moving. And if we take a close look at this, this is from 65 to over 90, and it's split into 5-year age groups. And once again, you see this shifting down. So that now what you see is a greater contribution in that 80 to 84 range and the 85 to 89 range and the 90 plus range. People are living longer, and as everyone knows, most of the costs you absorb in a healthcare system are in the last months of life. So if you're living longer, it gets pushed out. That's all that's going on here. And you can see the difference in the trend line from the 1998 age distribution in red to the 2008 age distribution in black. There isn't a big change. There are 2 caveats, though. Number one, it really depends on which province and territory you're looking at. If you're a provincial decision maker, that national aggregate data is of not much help to you. You've got to look at what's going on in your own province. And what we have in this country is an east-west cleavage. If you look at the Atlantic provinces, you can see that the bad cholesterol pretty much swamps the good cholesterol, and there's very little good cholesterol at all. In a place like Manitoba, it's pretty evenly divided. In places like Alberta, of course, population growth dwarfs aging. Now that's historical data, 1998 to 2008. 10 years from now, we'll be looking at something which looks a little different, at least for Saskatchewan, probably for Manitoba, probably for British Columbia, but it's probably going to remain largely the same for Atlantic Canada, unless that shipbuilding contract in Halifax is much bigger than... Now, there's a second caveat here, and that is it really depends what sector. I can say aging doesn't matter. That's not really true in specifics. It doesn't maybe matter for physician care or hospital care or drugs, all of which are 1% or less, but it really matters for long-term care. Now, you might say, duh, of course, it should. But this has enormous implications. It is not a sector that we have focused on. There's very little policy development thinking or long-term strategy about either facility-based long-term care or home care that could act as a substitute for long-term care. There's always been a little bit of discussion at the margins, but there hasn't been the kind of what I would call national focus on this issue that there probably needs to be. And if there's any area that we need to prepare for this impending sort of wave of aging baby boomers that are going to cripple the system, that's where it's going to be. That's the area that we need to look at very carefully. And it's not just money. It's about preparing the right kind of services, facilities, and trying to alter things so that you can achieve higher quality of care. And that's a very difficult equation. The rate of dementia-related conditions and the number of people living in higher acuity and suffering from dementia-related conditions in nursing homes has just climbed in the last 10 years. So the people there are sicker, and they're suffering much more difficult, there are conditions that are much more difficult to care for. And I think that intuitively many of us know that. It's just that we spend so little time in policy terms trying to grapple with this fact that I think I'm hoping at any rate that the Kai-Hai report will shed some light in this area and will encourage governments to really make this a focus of their attention. Certainly, they'll have an incentive to do so. Now, let's move to health sector inflation, one of those other categories. This is, of course, above the general rate of inflation. The reason I want to focus on, because these often involve factors that may be policy amenable. That's fancy public policy language. It means that it's something that a government can actually try to address, whether they want to or not, whether they're willing to face up to the stakeholders and the interest groups, all of the huge interests involved, that's another story. But it's within the realm of the possible. That's all that means. There's some things you can't deal with. Most provinces and territories really can't deal very much with aging. They're kind of stuck with their aging profile. They can, through really aggressive immigration policies, they can change it at the margins, but they're largely stuck. It's sort of a legacy thing and it's a gift that basically keeps on giving for a very, very long time, and there's not much you can do about it. But this is something you can do something about. And that's why governments are generally going to be pretty interested in this area. So, we're going to try to look at physicians, and we're going to look at hospitals in this area. And when you go to physicians, what you see is a 6.8% average annual increase in spending. And when you look at the components of that, and we have a database that allows us to do that, so we're able to get in here in a way that we're not able to get into other sectors. What we see is it isn't volume, it isn't utilization that's driving this as much as it's actual fee-for-service increases. And in this, it's 3.6%, which is well over half that average annual increase in spending. So, we know we have an issue here, right? Because we always used to think it was just about volume. But now we know something else is going on. And for some of you, it may not be a big surprise. There have been all kinds of efforts in provincial governments to try to, for example, provide incentives for physicians to do certain things, and those things have been added to the fee schedule. Things haven't been pulled out, they've just simply been added. Bonusing has been done in certain places, etc. That's going to have a cost. And the question is, are you getting the results that you want for the cost? I can't look at the results. I don't have the time to look at the results in this presentation. I'm just looking at the input side at this point. But we can talk about that in the discussion period. Now, what about hospital expenditures? What's going on there? Well, what you see here is we can't get in quite the same way that we got into physicians, so this is sort of the most that we can draw out. Again, aging is not a major factor. What we have, though, is general inflation and other. We don't know how much is technology, but we know in the hospital sector it's going to play a pretty big role. We just don't know exactly how much. And then we have health sector inflation, mainly health human resources, because that's most of your expenditures in terms of hospital care. It's not capital and equipment, it's actually health human resources. And of course, we do know that health system wages, I'm not talking about fee-for-service schedules now, I'm just talking about wages, are higher than the general economy. So there is a bit of an issue here. And I think most of the folks working in the sector kind of know about this already, but we're going to need to do more research and get better data as to exactly what's going on in the hospital sector to be able to say something more definitive. Okay, in both of these sectors, utilization doesn't appear to be a big issue. Everybody thinks that people are using doctors a heck of a lot more and going to hospitals a lot more. This data demonstrates that that is not the key factor. But there is an area where utilization, volume increases are critical. And that is in the area of prescription drugs. Now, the reason that I mention all of this in the first place is The very conventional wisdom is that the demand for healthcare is continually going up, and as we get older, we demand, need, or use more health goods and services. You can see that that's not quite the case in the so-called sort of Medicare core of hospitals and physicians. But something has happened in prescription drugs that's very important. You can see here that there's been an increase in the last 10 years, that is 1998 to 2008, of 6.2% per year increase in the use of prescription drugs. That's volume increase. That's not a mix in drug types. That's been separated out. That database allows us to separate it. It is strictly an increase in utilization. You'll see something else that's a big shock. I've bolded it. And that is there has actually been a negative price increase, which means that there's been a price decline. Now, why is that? That is because the development of new chemicals slowed considerably since 2000. This shows you the trend line here. The number of new drug classes is a solid line, and you can see that something has changed. In part, that's a result of certain categories or classes of drugs where we have seen basically a maturing of the patents. And you can see that for sure in cholesterol-lowering drugs, which has been the fastest growing drug class in the country over the last 10 years. So we do know that. This evidence is consistent with studies that are going on in other provinces. Steve Morgan has done studies on British Columbia and come up with basically the same results, but on a much finer detail. Let me just go back to technology. This is the other category. Now, the other is 2.8% in the overall scheme. We don't know how much of that is technology. Many would argue, based upon the evidence that they have from various sectors, that it's probably going to be well over half. But that's just a guess based upon the evidence. The difficulty with technology is that it can be both cost increasing or cost reducing, depending on the nature of it. The difficulty, of course, as you know, is that to implement new technology is always a very large upfront investment. To use business language, the capital cost is high, right? It's the operating costs that I'm talking about when I say it's cost increasing or cost decreasing. Does it bring down your operating costs or does it increase your operating costs? And again, there have been a number of studies, and some of you received this reading from David Cutler from Harvard, a major study published in 2007 on the long-term costs and benefits of revascularization after a heart attack, and found that you could get 1 year of additional life expectancy. This is the way that health economists calculate these things, at a cost of $40,000. That's a bargain in healthcare. Would you pay $40,000 for an extra year of life? I suspect many of you would. But at any rate, compared to many of the other things that we invest in, it's also a bargain. The question here is, overall, do we have the level of health technology assessment in this country that allows our health ministries to make these decisions effectively? And I recently came across a study which did a macro survey of health technology assessments in Canada and found that only 25% of them had even the beginning of an economic analysis. They're very focused on clinical effectiveness, but they are very deficient in terms of economic analysis, in terms of the relative cost and benefit. So we'll have to do a lot better in this country. We do much worse than countries like Australia in this area. And part of the reason is we just have too few health economists in this country. We don't have the capacity or the skills yet, and we'll need to develop those skills so that governments can begin to make those kinds of determinations with better analysis supporting them. These medical technologies involve devices and equipment, but also includes prescription drugs. And you might not think of health technology assessment in terms of prescription drugs, but that is being done all the time. It's being done by one pan-Canadian organization, the Canadian Agency on Drugs and Technologies in Health, and occasionally being done by a couple of the provincial agencies. So let's go back to that original diagram which shows the individual cost drivers and what's happened from 1998 to 2008, and talk about the other category in terms of that. So we have technology, health sector price inflation, but we also have other things that I haven't talked about that are in that other category that we're going to have to disaggregate over time. Now, here I'm not going to give you any answers. All I can say is the typical thing that a health services researcher says: more research is needed. And I apologize for that, but we really do need research on it, and that is the level of morbidity, lifestyle changes, etc. We have very limited evidence of the increasing impact on health spending growth, and there's a great debate. Are we getting healthier, or are we getting, in a sense, less healthy? And, you know, a lot of the conventional wisdom is we're getting less healthy, right? But there is very specialized evidence that says we're actually getting healthier. But we need to determine that, but we not only need to determine that, but we need to figure out what the impact is on our health system. Particularly when it comes to an area like long-term care and home care, where we have to basically engage in what I would call very long-term planning, looking at a time horizon of 10 to 20 years. We need much better information as to what we can and need to do. And some of this stuff is policy amenable. As difficult as it is, there is a role for policy interventions to change the trajectory. The next thing is there can be, in fact, a policy shift that can cause extra spending. This is the argument of some people, again without evidence, but this is the argument against the Canada Health Transfer. It has encouraged provinces and territories to spend, and to spend foolishly. And if it didn't exist, they'd be much more careful in spending. The theory behind that is it's basically free money, and they're going to spend it if they get it. The difficulty with that argument is it ignores the chain that it goes through. As I said, that money flows into general revenue funds, but then there is a general competition among all ministries for the funds within that basket. And I've never heard anyone say, oh, that money is only going to health and they can do whatever they want with it. It's a much better argument when you're talking about a fund which is hypothecated, separated, and only use that fund for that kind of money. That kind of approach exists in countries. It's called social health insurance. And there is definite evidence from France and Germany, those are social health insurance countries, that when the money is separated like that and protected from the budget process, that when you have more, you actually do spend more. It's there. And anyone who's familiar with how government works and how departments work towards the year end, as they have a little extra money, will know that that can happen. So, what are the policy implications? Yeah. What I've given you probably feels like a pretty pessimistic picture, but actually I don't think it's as nearly as pessimistic as the picture portrayed in the media. And I think that there's much more avenue in terms of policy interventions to deal with this situation. So I'm going to try to go through some of the policy implications in light of the current debate, which is very confusing in this country and does seem to be incessant, at least in terms of taking one position, which I'll mention at the end. The first is that most governments in this country are now running deficits again. That means that they're going to have higher debt service charges, and that means that at least on a pan-Canadian basis, it's the end of the fiscal dividend. So budgets are going to be tighter in general. This is going to cause additional pressure in health budgets because health can't avoid that competition. We have not segregated health out. We have not protected. We said it's part of that process. And in fact, I've demonstrated in a previous piece of work that in the early to mid-1990s, Canada was able to go further in terms of cost control on its health budgets than any other OECD countries because governments had that kind of direct control. In many countries, like the social health insurance countries, governments do not have that kind of control. They can't touch those hypothecated funds, right? But in a general tax system, you can get at them. And if, basically, health will have to share the pain if governments begin to go into a cost control mode. So, cost containment can be very different depending on how it's done, right? It can be strategic, it can be cautious in terms of keeping an eye on the long term, or it can be save costs in this year no matter what, and to hell with the consequences down the road. So there are different ways of doing it. But if health human resources is your main area of cost activity in most of your health envelopes, without a doubt, you're going to have to look at health human resource costs. Now, in this case, I guess I put a big target on physicians, but if you look at the hospital sector, it also means nurses and others that work within the acute care sector. And if we could look at those other sectors more carefully, we'd probably see inflation above the general rate of inflation as well. Now, some of this has been a response to market conditions. There's been, in a sense, some would argue, inadequate supply, excess demand. So any economist can tell you what will happen in that situation. Remuneration will go up. If we're in a different situation, governments are cutting budgets, and governments are the biggest employers, directly or indirectly, through the payment system, then you're going to see employment go down. And then we might have surpluses, and then all of a sudden, wages will go down naturally. Governments won't have to change a policy, right? Or governments can say, no, we're actively going to intervene here. We don't want to wait for the market to do its magic for the next 3 years. We're going to intervene, and we're going to deal with this problem now. So there are different options open to government for sure. In the area of drugs, governments have intervened quite considerably. I would argue that they haven't intervened adequately enough in the sense that it's basically been such a mixed up picture, provincial governments having in fact limited jurisdiction, so there's only so much they can do working alone. The federal government deals with patented drugs and price regulation in terms of patented drugs, but doesn't regulate generic drug prices, right? And provincial governments have to rely on very crude instruments like what's on the formulary and what's not on the formulary to cost control. The federal government and the provinces have decided not to continue with their discussions in terms of trying to come up with a better system that basically tailed off about 3 years ago. So we're in a bad spot there. And it's only a limited amount any one province can do, but there are still things that provinces can do in that area. No province, however, can regulate generic drug prices. The federal government questions whether it has jurisdiction to regulate generic drug prices, but for sure, the provinces don't have jurisdiction. So that's the issue. Now, the reason I'm harping on generic drug prices is we have the second highest generic drug prices in the world. For a lot of you, that, is a bit of a surprise because in the 1980s, generics were, in a sense, the saviors. They were protecting us from the big bad, patented RX industry. But the truth of the matter is that the drug industry has changed a lot. And you don't really have two camps, one based in Montreal, the prescription drug patent companies, and one based in Toronto, which are the generic manufacturers. It's all mixed up now. Second of all, you've got some integration in that you have companies with loose alliances or tighter arrangements in shareholding and ownership patterns in which you have generics and patented companies together. Now, I'm not going to accuse the drug companies of price fixing, but the Patent Medicine Prices Review Board, which provides data, clearly demonstrates certain patterns in pricing that would be very difficult to achieve unless there was at least a little bit of discussion going on. And that is attaching a generic drug price to the price of a patented drug. And so in this country, if it's, you can say it's 30 or 35% below the price of the patented drug, the reality is it should probably be much more than that. At any rate, there's a lot of work that could be done in that area. It is policy amenable if we have the courage to deal with it. Then there's population aging and long-term home care planning. That's largely within the purview of the provinces. Any individual province can take that on and should take that on. It's becoming a major issue. I would say that it would probably be something that would even be politically popular. And so, that might be a nice virtuous circle, actually. And then the investment in new cost-reducing technologies. This is the dangerous area because when you're in a mode of cost containment, one of the first things that you do is you stop your capital expenditure, right? And the difficulty here is that we lose the potential for cost-reducing technologies, and number two, we have an impact on quality. And that happened. In the early to mid-1990s, Canada fell well behind in terms of advanced diagnostic imaging, and the reason that it did so is because we were really in cost control mode, and we just basically cut our expenditures in that area. But it came back to bite us a few years later, and we're still playing catch up to a certain extent in that area. And then there's a lot of people in this country, and now this is really just my own editorial view, so you can discount it because you know where I come from on this, but there are a lot of people arguing in this country that the only way that we can deal with this problem of population aging and increase in cost of technology is to simply shift the burden from the public purse to you as individuals. And if you pay more directly out of pocket, that's somehow going to solve the problem. Well, I would argue that it displaces the problem, but it doesn't get rid of the problem. And in fact, it may make the problem much worse. And the evidence from countries that have tried to rely on that sort of shifting to get rid of the problem is it's been demonstrated that it not only costs you more as individuals, but it may cost you more as taxpayers because all of a sudden you're trying to encourage people to buy insurance to cover off those extra expenditures, and guess what? You've got to offer them subsidies. And the tax expenditure subsidies in this area are hellishly expensive. And they don't end up in the public accounts, so I can't even show you what they cost in terms of the United States. But that the amount devoted to public health care in the United States would be up much higher if it included tax expenditure subsidy payments. And the same for Australia, which invests a lot in tax expenditure subsidy to keep up its separate private tier. So I would argue that that is not the answer, but that is the answer, and that is the Rossum that you're hearing from a lot of people out there. So I would argue that we just basically have to accept that we have this responsibility as public decision makers from a public policy standpoint and get on with the work that's involved here. Thank you very much. Now, I just want to acknowledge a few people. First of all, I want to thank Kai Hai for letting me do the presentation, as I said before, and I want to especially mention Dr. Livio Di Matteo, who I asked to be a consulting economist for me on the project. Anytime I ran into a really difficult issue and I needed a second opinion, or I wanted him to offer up some of his expertise, he provided that during the term that I was working on this. And the fact that I drove him crazy as well as Kai-Hai crazy, because I did the second draft of the report while working at my cabin up north in Lac La Ronge, so to put up with my cell phone and my poor internet connection from my cabin. I also want to thank a couple of my WRTC students for actually reading an earlier draft and asking, is there anything that just doesn't make sense to you? And my program coordinator for dealing with the whole project from beginning to end. And as well, the Office of Research Services, because rather than taking on this contract as a consultant, which is what Kai-Hai wanted, I asked it to be a research fund to be set up in the university, but it was a very complex arrangement. Colleen basically had to manage getting that arrangement set up, and the Office of Research Services here was very good about it. And special announcement that there's going to be a conference on bending the cost curve in healthcare in Saskatoon on September 27th, 28th. It's a long time away, I know, but put it in your calendars. Come if you can. We're going to be addressing this whole issue of how best to bend the cost curve without damaging the access that we have to public health care in this country. We're looking not only at the Canadian experience in general, and the provincial experiences in particular, but we'll also be looking at the international experience, and there'll be some very notable speakers that will be coming to the conference. So please do come, and I believe there's a handout that's available to you on Bending the Cost Curve Conference. So that was a paid announcement. Thank you. Okay, questions. Should we turn to Saskatoon first? I apologize. Everybody was shaking their heads at me from back there when I was walking away from the mic, so I know that there were a couple of things that you couldn't hear. Am I going to ask myself questions or what? Well, let's move to Regina.
I'll ask you a question.
Okay.
So you're an economist and look at the macro level picture. This is not going to work so well. I'm an accountant. I look at the micro level and the front line, and I think when we look at costs going up in healthcare, well, the answers are obvious. You can look in the trenches and you can see them. Yes, the wages to nurses have gone up. Yes, there's a new generation of people that don't work. They're not as productive as they used to be. Yes, we have organizations that have grown monolithic and they're out of control and not able to manage themselves. Are we speaking the same language when I look in the trenches and say the solutions are in the trenches, and you're looking at a more aggregate level and seeing your perspectives from there?
Well, I guess what you're saying is that you can get a lot of really obviously good anecdotal information from the trenches. What we're trying to do is see if that's confirmed in the data, number one. Number two, some of the answers from the trenches may have it wrong. And the aggregate data should demonstrate that. And, it's not just people working in the health sector. I mean, there are journalists all over this country, and there are people in think tanks that think they're also in the trenches. And they look at the system, they say it's a disaster, and I know why, and I know how it can be fixed, right? So it's more a matter of questioning assumptions. There are not too many answers in this. A lot of translation needs to be done before you can come to answers. All I did was, I called it policy implications, right? But for sure, there are important decisions to be made by ministries of health in this country. They have to decide whether they're going to trust the organizations that they've created to manage this problem, or whether they're going to go into a command and control mode and use another mechanism or use a combination of the two. And the example that I'll bring up is the National Health Service in England, which basically a few years ago tried to use a command and control system in a system that had already become fairly devolved. It had been a very centralized system, but it had become fairly devolved. And they did an interview of all of the people that were actually the CEOs that were managing the healthcare organizations, and their response to the directive of the Minister of Health and the senior level of the NHS. And they described what happened after. And to me, that seemed like the worst of all possible worlds. That is exactly the result you do not want to have. The sort of incentives and the disincentives, the carrots and the sticks that were used, actually produce a lot of unintended consequences, many of which actually produced exactly the opposite result of what you were trying to achieve. So we want to avoid that kind of a situation. And I can't speak to that, but there are people that are working in health ministries and in regional health authorities. These are the questions that they are going to have to ask themselves, and no doubt are right now. And there's a lot going on right now. Yes?
You spoke about within the physicians, fee-for-service being the biggest cost driver there. And I was wondering whether you thought that was unique to the fee-for-service. You made allusions to incentivizing or whatnot, or if physicians, due to their position or whatever, were just so successful at negotiating wages, if we had a wholesale conversion to salary, we'd just see at the next analysis the same sort of increase in capitation.
The short answer is I don't know. But I can tell you that the data is restricted to fee-for-service. There have been some efforts to try to deal with alternative payments and what's going on there. The preliminary evidence is that we've seen the same kind of inflation in the alternative payment category as the fee-for-service, so that might speak to your issue. But there's not much, I wouldn't call it salary. The alternative payment is a mixture of things, many of which are not salary at all. So I don't know what to say on that one. But certainly physicians, like other groups, have been very effective in bargaining with governments. But they've had leverage that they didn't have in the early to mid-1990s, where they did poorly. And they did poorly because governments had the leverage at that point, and it was strictly caused by this issue of whether there was a surplus or there was not a surplus. And in a situation where governments aren't investing, you basically create a surplus. And all of a sudden people don't have the same bargaining leverage.
We have a question in Saskatoon.
Oh, okay, sorry. We'll do that first then. Sorry.
Hi, Greg. You mentioned general. Our healthcare is the NHS system, which is financed by general revenue. So there's ups and downs according to surplus or deficit of the government position. Do you think there are any mechanism which can keep government spending more disciplined, accountable? For example, physician service, about their outcome.
Well, disciplined I'll deal with in a second, but accountable, it is accountable. And in fact, I think the general revenue fund system through cabinet governments and a parliamentary system is pretty highly accountable. But it's up to, obviously, the opposition, the media, and the public to scrutinize what government is spending. But surely all of the mechanisms are there, and it's a pretty transparent process overall. As for discipline, well, governments either discipline themselves or they do not. Whether there are external mechanisms that you would want in terms of discipline, maybe you could argue that the Auditor General of Canada and the provincial auditors are a discipline mechanism, given that they're now heavily involved in value for money analyses, right? So that's one sort of mechanism. You have a legislative officer at the federal level, which is also providing, I think, what I would call alternate advice to the Canadian public concerning the budgeting process. So I don't know what else you could do beyond those things. It's rooted in a democratic system in which ultimately we have to look at ourselves in the mirror and say, are we holding our elected representatives accountable for this? I don't know what specific ideas you would have in mind, but, some would argue, in fact, that it's been extremely disciplined and it's been very responsive. And in fact, what you see in terms of the increase and decreases over time, that cycle, is actually a response to policy exigencies, and that is a very good thing. Others who work in healthcare might argue that that's a very destructive thing, and we need to create a mechanism to ensure that we don't have those valleys and those highs. And you can do that by creating it's kind of a social health insurance approach, which is a hypothecated fund. But the evidence, as I told you, is that we overspend when we have the excess funds in those hypothecated funds. And that doesn't strike me as a particularly good mechanism. So maybe I'm a traditionalist, but I kind of like the system that we have with all of its deficiencies because I don't see a better system out there. Is there another question from Saskatoon before we move to Regina?
Hi. Can you hear me?
Yes.
Good. You mentioned home care and the kind of the final years of life as being one of the most expensive periods in our lives for the cost of health care. I'm wondering what you might imagine how we might respond in terms of keeping those costs down. Are there different systems, different ways we might organize our communities where we might reduce those costs? I think I've just come back from Europe, and I see there's in many countries in Europe, there's different ways that families are organized, the extended family, whereas parents and grandparents are kept in the home much longer than they are in Canada. I know in Calgary they have a home share program where university and SciAS type students will pay very low rent to stay in a senior's home in exchange for services provided by the student to keep elderly people in their home longer. I'm wondering, what might you be aware of that people are imagining anywhere in the world where we might reduce the costs of those final years?
Well, you've mentioned some of the changes. Those are changes, that involve local governments as well as sort of, in this country, provincial level governments, but mainly local government changes in terms of zoning, etc. And then there are changes that just can be done voluntarily. They don't require policy interventions, but they will reflect a particular culture that just may take a great deal of time to change. And so I don't really know how to speak to that, but I would say that in terms of facility-based long-term care, there is a lot of experimentation going on. In the Netherlands, for example, there is a lot of work in terms of the division between patients with dementia-related conditions from those who are suffering other physical disabilities, and caring for them in a very different way. They live in very different circumstances that are quite a bit more sort of conducive to their condition and to their quality of life. That doesn't mean that it's less expensive. In fact, there's some evidence that it can actually be more expensive because it involves more intensive care. But connected to that, and this is some of this work that's going on in Denmark, which has one of the best, or did have one of the best home care systems around, and really did encourage people to stay at home for much longer periods of time. But that involved a fair amount of casework and what I would call professional assistance in the home beyond caretaking. And that again involves a fairly significant investment. In Canada, we do see fundamental differences in our home care programs across the country, and a lot of sort of natural experiments that we could look at to see how well they work. But it's got to be done in sort of and examined as part of a continuum of care, where home care and facility-based care are seen as a continuum, and that one may become more appropriate at a later stage of life, but for as long as it makes sense that home-based care be made available, even though it will increase in cost to that point over that cycle. So I think there's quite a bit that we can do.
We have a question here in the boardroom, Greg. Do you have time for that?
Sure.
Thanks, Greg. I have a question regarding the comment you made earlier about the lack of health economics or health economists to do adequate or appropriate value for money analysis for a lot of these departments. And it seems to me that it's a simple economic problem. There's excess demand and not enough supply of health economists. So do you see maybe a trend of this changing in the near future where we are producing more people who are suited for that role? And if not, is there like a structural or institutional barrier to producing health economists, essentially, that can fill this demand that you see that we have a need for?
Yeah, there's a demand and a supply problem. One is that we don't bother even trying to fill the positions or creating the positions, so that our health technology assessment organizations, they don't actively say that you have to do economic analysis as part of the HTA, and therefore you just avoid the issue. So you're not making the demand. And you could hire people from other countries in the meantime, but that's not being done on a major scale. And then, of course, there's a supply issue. We don't actively produce very many health economists in this country relative, for example, to the United Kingdom or to Australia, or even to the United States. And as a consequence of that, we don't have the domestic supply. But again, if there was the demand, the supply would come, I'm sure. So it's more a matter of what our organizations demand going forward. The universities will respond. They always respond to these opportunities over time. They're slow, but they respond. We have a question here. Tammy?
I'm not sure I'm quite in the right place in the conversation now, but my question was about, if we look at inflation of salaries and put it in the context, it seems to me there's a spike right around when the Accord and the 10-year health deal was done. Is there something you would do differently or recommend be done differently this time around to send the right signals that that's not? It seems to me we sent signals about 6%. There's an inflationary signal there, right? Yeah. Is there something you would do to mitigate against that? And is it conditions, or what would it be?
Yeah, well, there's a couple of things there. Number one, correlation does not mean causation. So, we don't know exactly. But for sure, there was a signal sent on the 6%. It was like, okay, it's okay for that to happen, right? It's okay for this. And in fact, that became the baseline. It was like 6 went down to 0, and anything above 6 sort of became the new normal. Maybe. And, I don't know to what extent that enters the minds of treasury boards when they're making their decisions. I would say I don't think it does, but I'm not sure. I don't think they sit around and say, well, you remember that discussion about the 6%? It's okay if we let health off the hook because their normal is 6%, but everybody else's is 3% or 4%. I don't think they actively. Yeah,
Can I
I think so.
is this appropriate for a question from Saskatoon?
Okay, is this a carry on from that question? Sure.
No, it's a different question.
Okay.
And you mentioned generic drugs and how Canada, the cost of generic drugs in Canada, which is regulated by the federal government, is much higher than in many countries. What can I do to encourage our federal government to have a serious look at that to lower the cost of our generic drugs?
Write your MP and ask your MP what's going on in terms of a national pharmaceutical strategy, and that you're very concerned about the price of generic drugs, and enclose the latest report from the PMPRB, the Patent and Medicine Prices Review Board, that demonstrates where Canada sits relative to all other OECD countries in terms of its generic drug prices. That could actually have some impact, I think, because right now it's off the radar screen, and this would help put it back on. And if you write a formal letter, somebody has to respond. Any other questions here?
I've written many letters regularly to ministers, and typically it's their administrative assistant, whatever, that writes me back some form letter. Beyond that, is there something that beyond that? I'm serious. Beyond that, like I belong to a group of people that are fairly active in terms of bicycle trails and food management, all that kind of stuff. And this is an issue that we just might take on. We would write to our MP, that's not a problem. But beyond that, what might
beyond that, it would making it, writing on behalf of an organization or making submissions to a minister or asking to meet a minister as an organization, or your local MP as an organization. The other thing is, if you're a member of CARP, Canadian Association of Retired Persons, getting it onto that agenda, if you have any influence in that organization, that could be very, very effective. I'll tell you, when CARP says something and puts forward a policy position, governments listen, particularly the federal government.
Thanks very much.
I'm not really a good advisor on advocacy groups. It was never my expertise, I must admit.
Helpful, thanks. That's helpful. Thanks very much.
Any final question from here? Mike.
Greg, when I look at the data you had at the front end of the presentation, the proportion of healthcare spending as a proportion, as a ratio of the population, the wealth of the nation, GDP, over a 30-year trend, it went from something like 6% to something like 8%. And I look at the data you had for your decade from 1998 to 2008, and it looked as though the trend for proportion of budget expenditure on health was normalized or had regularized around 43 or 44%.
Yeah.
Do you agree that
just under
sustainability? Do you agree that sustainability is the overwhelming issue in healthcare that we should be addressing?
Well, sustainability is a really problematic term. I only used it because it's being used in the media. I hate the term. I think it obscures more than it reveals. What we should be talking about is, efficiency and effectiveness. And in those terms, there's lots we can do, but I don't think that public sector sustainability is defined as immediate as an issue. I think that's a false issue, and it gives you a false answer, and it takes you in exactly the wrong direction. But I think it's purposely intended that way sometimes.
Can I ask you about how CIHI develops its data and its analysis? Is there engagement with interest groups with respect to their interpretation of the data that is collected, and in fact, the validity of the methodologies they use to collect their data? Because I'm going to ask you the question, when this data is presented, will it be attacked by those whose interest it doesn't serve?
There's a very lengthy process involved, and major stakeholders, particularly the provincial, territorial, and federal governments, plus the various agencies, many of which are arm's length, are involved in a very private process of briefings. And there were 3 technical reports that were done by CIHI, and they briefed their stakeholders at every point on those reports after they were done and after they were satisfied. This was months ago. In terms of physician groups and nurses, etc., in terms of organized medicine, organized nurses, there are key people that already know what this data is revealing. And they have been informed because they provide data to CIHI directly, and in return for providing that data, they're given an advance peek at what the data is telling them. And there is a lot of discussion on definitions, what the data means, whether the data is reliable. Now, these are the very people giving the data, so in a sense, they've got a lot of skin in the game in the first place. But second of all, of course, they're going to be concerned about what the data may be telling them. And that's why CIHI does not engage very much in an interpretation of the data from a policy perspective. So a lot of what you see is my gloss on it, but they can't do that because they would lose their stakeholders immediately. They go as far as they can go without losing that constituency. And it's a very hard sort of line to draw. But I will say this for CIHI. I mean, it's a huge repository of administrative data. And when CIHI started, for the first 5 years, everybody was very pessimistic about CIHI and what it could accomplish, and were pretty negative about the future of the organization. Well, it eventually found its feet, and I have a number of European friends that tell me over and over, and they just say, just wish that we had the data that you have. It's unbelievable font of administrative data that's available to you without having to go through any hoops. Second of all, they're involved in a consistent process of improvement of the data and expansion in terms of the database sources. So I think that we've been pretty well served by that instrument in this country, and it's the only way we could have done it. We had to use this kind of a decentralized instrument. It could have never been done by Statistics Canada, for example.
We have another question here in the boardroom, Greg.
Just 1 second.
I was going to say, for the people in the room who don't know, CIHI's current CEO and the previous CEO were former Deputy Minister of Health from Saskatchewan.
Yeah, that's right. That helps too. Mike, I was hoping you wouldn't say that. Sorry, we have one question from the boardroom, and then we better...
One question from the boardroom here. Go ahead.
Okay. Greg, it's Milo Fink here. I'm probably one of the only physicians in the audience. I want to follow up on your comments about effectiveness and efficiency because that links, in my view, to the current policy in Saskatchewan around lean. And as a cost driver, I wonder if you can comment on measuring effectiveness and efficiency from the perspective of an economist. And lean.
Oh, boy, that's a huge question. There are 2 things that are involved. Now, this is just the Coles Notes version, so I guess that reveals my age. A very simplified version. There are 2 parts involved when an economist does this kind of work. The first part is to try and determine whether more can be obtained from the existing stock of resources. So, without adding any additional resources, is it possible to get more? Second, it's given the extra cost that would be required to introduce something new that is aimed at improving effectiveness, is there anything else that you could do in the system at the same cost or less that would actually produce an even better outcome? It can be in a completely different area. So the notion is to actually make comparisons across the system to try and find what is what we would call the very best use of that existing money for that investment. And that is not the way we do things in budgeting generally. We don't think of the alternatives. We don't say, well, if we had an extra $100, would that be the very best way to spend the money, or should we actually spend it in doing something on immunization or something else? We generally make the comparison within the narrow sector itself. The economic analysis opens it up more broadly, but when you do that, it introduces enormous complexities. And I'd be the first to tell you that this kind of economic analysis has been questioned over and over again in terms of its actual utility on the ground in terms of helping decision makers make policy decisions because of the complexity of making those kinds of apple and orange comparisons. That's all I want to get into at this point, because this would be like an hour seminar on the issue. All right. Well, I just want to thank everybody so much for coming out and your questions. And if you have any additional questions, don't hesitate to send me an email or grab me for a few minutes right now. I teach in about 15 minutes, but I have a few minutes before I leave. And thank you, Saskatoon.
Thank you.